Good afternoon. My name is Lieutenant Commander Lauren Suzanne, and I'm accompanied by Commander Catherine Cadet, and this is our tech talk on medical procedure simulators. Both Catherine and I are assistant professors in the Graduate School of Nursing, Nurse Anesthesia program at the Uniformed Services University. We chose this topic because as educators, we have found the importance of procedural simulators, especially in the specialty of anesthesia. This is our content map. We are going to cover the historical state of medical simulators, the relationship of medical procedure simulators to modeling and simulation, how medical procedure simulators are used in education and the current state of the art, and then we're going to look at the future of medical procedure simulators. So first, we're going to look at the history of medical procedure simulators. The first modern simulator was an interactive procedural trainer that was developed around 1700 by Gregor and Gregor. They were a father and son team in Paris, France. This simulator was developed from a human pelvis and a dead baby. It was used for teaching delivery methods to midwives and resulted in a decrease in infant mortality. In the 18th century, in France, Angelique Marguerite Labourse de Cordier used a cloth birthing simulator to teach her techniques to midwives and surgeons. Similarly, in Italy, Dr. Giovanni Antonio Galli developed a birthing simulator for training his students in midwives. The use of body-specific trainers preceded the use of full-body anatomical models. Published examples of pelvic models and pelvic machines used to train midwives can be found dating back to the late 1700s. Obstetric simulators called obstetric phantoms were available in the early part of the 20th century.
See if we can, see if it works. Hold on, let me pull this up. All right, which one is that? History continued. Let's see. All right, I'm ready when you are.
Okay. So not surprisingly, nursing was one of the earliest adopters of simulation in the healthcare profession. The use of simulation in nursing dates all the way back to Florence Nightingale. Known as the mother of infection control, she used simulation in her demonstration of proper methods for infection prevention. By the mid to late 1800s, nurse training programs were using medical procedure simulators to teach tasks such as bandaging and bathing, specifically on limbs. Then, in the early 1900s, the most famous initial full-body mannequin was introduced. The mannequin was modeled after its creator, Martha Chase, who was a children's doll maker. Martha was asked by Lauder Sutherland, the principal of the Hartford Hospital Training School, to make an adult-sized mannequin for use in training nurses at Hartford Hospital. Lauder had become tired of using straw-filled dummies to train her students, and so the mannequin, named Mrs. Chase, was introduced in 1910 and was described as a full-body, static mannequin with realistic structures and included jointed hips, elbows, and knees. In 1940, Mrs. Chase created an additional mannequin named Arabella. It was an upgraded version of the mannequin that allowed student nurses to practice more procedures, including arm injections. Although the name Arabella never really stuck, I think we can't talk about the history of procedural simulators without discussing one of the most recognizable simulators, Resusci Annie. Dr. Peter Safer, who was working at a Baltimore City hospital, described the mouth-to-mouth technique for resuscitation. His work was recognized by many across the world, including a Norwegian anesthesiologist, Bjorn Lind. Dr. Lind convinced a Norwegian plastic doll and toy maker, Osmund Lerdahl, to design and produce a realistic model of a human torso that would allow the application of Dr. Safer's head tilt, chin lift to relieve airway obstruction and deliver mouth-to-mouth rescue breaths. At Dr. Safer's urging, there was the addition of a spring mechanism inside the chest of Resusci Annie to allow for chest compressions. This was the origin of one of the most widely used CPR mannequins of the 20th century. I find it interesting where the name Resusci Annie actually came from. It was actually inspired by a popular European history of a young girl that was found dead and floating in the River Seine, and that was back in the late 1890s, and that's where Resusci Annie received her name. So why are procedural simulators so important to the healthcare profession and modeling and simulation? Well, preventable medical errors are believed to be one of the largest causes of death in the United States, resulting in approximately 400,000 deaths per year, and there are injuries resulting in the disability of approximately 3.5 million patients per year in the U.S. alone. These numbers are alarming and have not significantly changed healthcare. These numbers are alarming and have not significantly changed healthcare education in the last 100 years. Instead, healthcare education continues to focus on didactic education, followed by an apprenticeship-style training. There is a lot of room for improvement, and the tools to reduce the potential for patient harm exist in modeling and simulation. Due to advances in medicine, specific procedures are performed less frequently, leaving fewer opportunities for learners to acquire these skills in the clinical setting. Even though there are decreases in the frequency of many procedures, clinicians in training are still expected to be able to perform these procedures, often on an emergent basis. The gap in the ability to perform procedures to gain competence can leave patients at risk for injury. One example is ultrasound and interventional radiology advances. They have resulted in less landmark guided procedures being performed, but this is still often required in an emergency situation. This is especially true in the forward deployed settings of the military, where we often have less equipment and face catastrophic emergencies. Procedural simulators can fill in gaps to achieve competence in different techniques for performing various procedures. So, procedural simulation and teaching models. Using a task trainer or procedural simulator can allow for the creation of a simple teaching model leading to a standardized teaching approach and ultimately a sustainable outcome. For many years, the standard of practice in the medical community has been Halstead's see one, do one, teach one. But this is becoming less acceptable, particularly when invasive procedures and high-risk care are involved. A more efficient model for teaching procedures, and specifically simulated procedures, combines the aspects of adult learning in Peyton's 4-step approach. In this model, a teacher can demonstrate the procedure on the task trainer or procedural simulator to the learner with no commentary as the first step. For the second step, the teacher actually deconstructs the procedure and explains each maneuver on the procedural simulator as he or she performs it. For this third step, the teacher can test the comprehension of the learner by having the learner describe each step as the teacher performs the procedure on the procedural simulator. The final step of this model refers to the student actually performing and executing while describing each maneuver on the procedural simulator to show competence. With a task trainer, the teacher can go through Peyton's 4-step approach to allow for more effective learning and produce mastery of skill of the particular procedure.
As we know, the use of procedural trainers is not new in medicine. Over the years, as technology has advanced, so has the fidelity, realism, and capabilities of procedural trainers. As medical training has increased its emphasis on simulation, the need for procedural trainers has also increased. While advances in procedural trainers have allowed for increased realism, there is still a need for the use of low-fidelity trainers in medicine. It is not uncommon these days for learners to begin training on low-fidelity procedural trainers and then progress to more realistic and complex trainers as their skills and knowledge improve. Low-fidelity trainers are still some of the most common trainers used in medicine. There is a large variety of commercially available low-fidelity procedural trainers, and their cost is relatively low compared to their high-fidelity and more immersive simulation counterparts. In anesthesia, the most commonly used trainer is a simple airway mannequin. The one shown in this slide is actually more advanced than some of the current models that are available. Simple procedural trainers for central line placement are also common. These procedural trainers are easily transported and stored, and providers can easily access them or move them from place to place in order to practice skills without initiating patient harm. Low-fidelity procedural trainers are a great way for beginner learners to learn procedural steps and form muscle memory for the completion of medical procedures. Commercially available low-fidelity trainers still have a relatively high cost associated with their purchase and maintenance. Many smaller facilities and programs may be unable to afford the large upfront cost of these trainers. This has led some individuals and programs to research non-traditional methods for procedural training. One non-traditional method of training involved the use of 4 different fruits, oranges, bananas, kiwis, and honeydew, for assessing loss of resistance in epidural training. The 4 different fruits were housed in a purpose-built box to conceal the identity, and then seasoned anesthesia providers assessed the realism of the loss of resistance on the 4 fruits. 62% of the participants recorded that the banana was the most realistic. Bananas are cheap and easily available and can be a training tool for the introduction of loss of resistance to the novice anesthesia provider. This may be an excellent opportunity for novice anesthesia providers to learn a loss of resistance feel without inserting an epidural into a real patient. Additionally, pork, beef, and lamb joints have been studied and have been shown to be effective models for the use of simulation training for needle skills for the performance of peripheral nerve blocks. Meat does have a limited lifespan, but due to its relatively low cost, it is feasible to discard the meat after each of the training workshops. It is a way to provide an inexpensive training environment for the use of ultrasound, and it can make the training more accessible and less expensive for institutions. The use of non-traditional or non-commercially manufactured procedural trainers is not new. Many programs for newly diagnosed diabetics teach individuals how to administer insulin on an orange, and for years, medical providers have practiced suturing skills on pig's feet, which can be obtained from the local market. As previously mentioned, the cost of procedural trainers can be very prohibitive for individuals and institutions. Access to and the availability of procedural trainers can prevent learners from being able to train on commercially available procedural trainers. While healthcare training programs may have procedural trainers, they may not be easily accessible to all learners for a variety of different reasons, including the hours of the simulation center or a low inventory of procedural models, making it hard for multiple users to engage in training all at once. Due to this, some learners have begun to develop their own DIY or homemade trainers. A quick search of the internet will provide you with a variety of blueprints and instructions on how to make your own trainers for a variety of healthcare procedures. Homemade procedural trainers are becoming so popular and widely accepted that instructions for their use and construction has been included in several healthcare publications. A recent article in the Journal of Ultrasound Medicine provided the instructions for a simple and easy to use nerve block phantom using a hot dog core embedded in a gelatin psyllium hydrophilic muciloid fiber mixture, commonly known as Metamucil. Interestingly enough, the homemade phantom showed little to no posterior shadowing, and the users reported a very positive experience in its use. Although basic models might be more useful for novices, advanced models allow for complex and more realistic simulation training. High fidelity allows for the acquisition and or optimization of skills in a highly realistic simulator and have been shown to improve knowledge and confidence. High fidelity procedural trainers include transesophageal echocardiography, or a TEE, and allow users to practice using an actual TEE probe. There are point-of-care ultrasound, or POCUS, trainers that allow learners to practice multiple different exams utilizing the same simulator. These highly advanced procedural trainers allow users to experience real life or true to life examinations utilizing equipment that they will be using in their actual practice. One of the most high-tech TEE simulators allows learners to provide anterior retroflexion, lateral flexion, and omniplane rotation, as well as utilize color and pulsed waveform, as well as continuous waveform Doppler. High-fidelity procedural trainers have the ability to interact with learners and have been adopted for the use of teaching non-technical skills as well. While not a technical procedure, the delivery of bad news is something that all providers and healthcare practitioners should be comfortable with, and the use of high-fidelity simulators has been shown to increase provider confidence with this skill. The future of procedural simulators is wide open. In medicine, there is a need for tools that accelerate learning and enhance the realism of training as medical procedures and responsibilities become increasingly complex and time constraints are placed on the trainee work environment. Virtual reality and other novel simulation technologies are now being adapted for medical education and enhance further interactivity, immersion, and the safety of medical training. Advantages of virtual world include higher time cost effectiveness as compared to mannequin-based simulation and face-to-face lectures, meaning it is cheaper to conduct training in a virtual environment than it is face-to-face. Two major disadvantages to virtual reality training are technological issues and lack of realism. However, it is proposed that as technology advances, these will become the disparities here will be decreased. In one study studying 3 learning outcomes, skill-based, cognitive, and affective learning, it was found that the virtual worlds were most effective in improving cognitive outcomes such as theoretical knowledge. This suggests that virtual worlds may be used as an alternative for complementary method to teach theoretical knowledge in healthcare education. As 3D printing has become more popular and accessible, it has also begun to be integrated into medical simulation. Recently, 3D printing has become integral to the production of limited quantity, low-cost simulation models across a variety of medical specialties. In general, production cost is a small fraction of the commercial generic simulation model, and these simulators, with their high costs, is usually from research and development. Simulators and medical training models that are 3D printed can be customized to the needs of each institution or learner and can serve as an integral part of the medical education. Recently, a 3D printed neuraxial phantom cost about $13 to print, required only 25 hours of non-supervised printing and a total of 2 hours of assembly time. This is compared to the average cost of a commercially available Neuraxial Phantom trainer, which starts around $400. In one study, a 3D printed Phantom was found to be less realistic for surface palpation when compared to the commercially available Phantom due to the fragility of the silicone that was used in its production, but it had a significantly better fidelity for the loss of resistance of a dural puncture and the ultrasound imaging compared to the commercially available Phantom. Low-cost Neuraxial Phantoms with fidelity comparable to commercial models can be reproduced using CT data from hospitals and provide a low-cost method to increase the accessibility of procedural trainers. In order for procedural simulators to become more realistic, there is a need for them to be more representative of the general population. A recent study found that the majority of simulation models available for educational use generally lacked diversity in skin tone, age, and body habitus. Limitations in mannequins and videos also existed. With most available options in mannequins were representing a well-developed, fit young man. Mannequin offerings in dark skin tones were typically only limited in lower fidelity options and were often only used for the portrayal of trauma, wounds, or a sexually related theme. The diversity of virtual and online simulations, however, tends to be greater. Research has suggested that the adoption of simulators that include an increased diversity in age, gender, skin tone, and body habitus has the potential to significantly impact medical training and the provision of empathetic and humanistic care while reducing sex and gender-based healthcare disparities. This is a complete list of our references.